Welcome to Fun Facts Online. Today, we are dissecting a silent revolution in modern medicine. For decades, the narrative of surgery has been passive. You get a diagnosis, you get a date, and then you wait. That waiting period has historically been a dead zone, a time of festering anxiety and physical decline. But that era is dead. We are moving from the waiting list to the preparation list. We are talking about prehabilitation. This isn't just about getting fit before a procedure. It is about fundamentally reprogramming your biology to survive a trauma. To understand why this matters, we have to look at what happens when you go under the knife. When a surgeon makes an incision, your body does not know it is being helped. It thinks it is being attacked. This triggers the surgical stress response, an ancient, evolutionary defense mechanism. Your sympathetic nervous system floods your veins with adrenaline and cortisol. Your heart rate spikes. Your blood pressure rises. And then, your body shifts into a catabolic state. To fuel this defense, your body starts breaking down its own skeletal muscle to create new sugar and proteins. This is why patients feel so weak for weeks after an operation. They have literally dissolved their own muscle tissue to survive the trauma. Simultaneously, you develop temporary insulin resistance, a condition known as stress diabetes. Your cells stop using glucose efficiently, blood sugar rises, and your risk of infection skyrockets. On top of that, you face an inflammatory storm. Cytokines like IL-6 and TNF-alpha flood the system. While necessary for healing, too much inflammation leads to organ dysfunction and immune suppression. This is the biological battlefield. Survival depends on your physiological reserve. Think of this as the gap between sitting on the couch and running for your life. Specifically, we look at the anaerobic threshold. This is the point during exertion where your heart and lungs can't supply enough oxygen, and your muscles switch to anaerobic metabolism. Surgery increases your oxygen demand by up to 50%. If your physiological reserve is low, if you hit that anaerobic threshold just walking up the stairs, the stress of surgery pushes you over a cliff edge. Your organs starve for oxygen, leading to ischemia and failure. Prehabilitation is the science of moving that cliff edge. It expands your reserve so you can absorb the surgical hit and stay safe. Deep inside your cells, we are targeting mitochondrial biogenesis. We want to activate the PGC1 alpha pathway to build new mitochondria, making your cells more efficient at extracting oxygen and reducing toxic oxidative stress. So how do we do it? We use 3 pillars: physical, nutritional, and psychological optimization. Let's start with Pillar 1, physical optimization. This is not casual exercise. This is a prescription. We have 4 to 6 weeks to remodel your cardiovascular system. The old way was moderate intensity continuous training, like a long, steady bike ride. It works, but it is too slow. The gold standard now is high intensity interval training, or HIIT. We need to spike the heart rate to 90% of its maximum for short bursts. Research shows HIIT triggers those mitochondrial adaptations and boosts VO2 max in half the time of steady cardio. A typical protocol might be 4 minutes of breathing so hard you can't speak, followed by 3 minutes of recovery, repeated 4 times. Then, we have resistance training to fight sarcopenia, or muscle loss. Remember, the body is going to try to eat its own muscle after surgery. We need to build a muscle bank. We focus on compound movements like squats and rows because they release myokines, signaling molecules that are anti-inflammatory and protect against surgical stress. We also can't forget the lungs. General anesthesia suppresses your drive to breathe and collapses the small air sacs in the lungs. We use inspiratory muscle training, which is like lifting weights for your diaphragm using a resistance breathing device. This significantly cuts the risk of postoperative pneumonia. Now, for Pillar 2, nutritional optimization. You cannot build a house without bricks. The waiting list is often a time where patients lose weight or develop sarcopenic obesity, normal weight, but low muscle. The standard protein advice of 0.8 grams per kilogram is garbage here. Prehab patients need 1.2 to 2.0 grams per kilogram per day. If you weigh 70 kilograms, you are looking at up to 140 grams of protein daily, preferably from whey for that high leucine content to trigger synthesis. But we go further into pharmaceutical-grade nutrition, known as immunonutrition. We use a holy trinity of nutrients: arginine to improve blood flow and T-cell function, omega, 3 fatty acids to dampen that cytokine storm and reduce inflammation, and nucleotides, which are the raw building blocks of DNA for your rapidly dividing immune cells. Protocols suggest drinking shakes with these ingredients for 5 to 7 days pre-surgery to cut infection rates by half. And please, forget the old rule of fasting after midnight. Starving depletes your glycogen and spikes insulin resistance. The modern ERAS protocol calls for carbohydrate loading. You take complex carbs the night before, and a clear carb drink 2 hours before surgery. You hit the operating table in a fed state, keeping your metabolism stable. Pillar 3 is psychological optimization. The brain controls the body. Anxiety drives pain and suppresses the immune system. We have to fight the nocebo effect, where fear becomes a self-fulfilling prophecy. We use cognitive behavioral strategies to reframe the patient from a victim to an athlete in training. Visualization techniques where you imagine the recovery have been shown to lower cortisol. Diaphragmatic breathing helps toggle the nervous system from fight or flight back to rest and digest. Beyond these three pillars, we have to look at medical lifestyle optimization. If you are anemic, we need to fix that iron deficiency immediately with IV iron, not wait for a blood transfusion risk later. If you are diabetic, we need that HbA1c below 7% to stop bacteria from thriving in your sweet blood. If you smoke, stop. Carbon monoxide binds to hemoglobin 200 times stronger than oxygen, suffocating your tissues. Quitting 4 weeks out improves healing. Quitting 48 hours out helps your lungs clear mucus. And for alcohol, 4 weeks of abstinence restores your immune function. This approach is even working for the frail elderly, proving that frailty is reversible. We can downgrade patients from frail to robust. For cancer patients, prehab acts as a bridge, preventing the physical decline caused by chemotherapy so they are strong enough for the tumor resection. Finally, looking to the future, we are seeing the rise of digital prehab. Wearables tracking heart rate variability and sleep allow doctors to monitor patients remotely. Soon, AI will build digital twins of patients to simulate surgery and test if their physiological reserve holds up. If not, the AI will prescribe a specific prehab regimen to fix it. This democratizes access, bringing world-class preparation to anyone with a VR headset or a smartphone. To conclude, the message is simple. The waiting list is dead. If you are a patient, do not be a passenger. Ask your surgeon what you can do now. If you are a healthcare system, realize that protein shakes and gym sessions are cheaper than ICU days. Surgery is the event. Prehabilitation is the training. Recovery is the victory. Welcome to the new standard of care.